I want to welcome you to this session on Clostridium difficile, infection, impact, and intervention. I think we're all aware that there's been a large increase, or we're seeing increases in the numbers of Clostridium difficile infections in our hospitals as well as in our communities. And this is some of the things we want to talk about during this session. So let's begin by asking a very simple question: what is C. diff? And we may shorten the name Clostridium difficile infection to C. diff during this. Now, this organism was first described in 1935, quite some time ago, as isolated from feces then from actually normal infants. And it was named Bacillus difficilis because of the difficulty the laboratorians had in isolating this organism, growing it on culture media. It was only recognized as a pathogen in the late 1970s. Now, diarrhea, as all of us know, is a very efficient method of spreading any organism, particularly the spores of Clostridium difficile. So if you team this idea up with the concept of hands that are not washed properly, things that touch contaminated objects, we really have a great way then to spread this infection throughout a hospital or a portion of the hospital. This is a rod-shaped organism that causes inflammation of the colon, or colitis. Now, it produces two toxins, a toxin A and a toxin B. And toxin B in this slide is red, labeled red, simply because toxin B may be more important than toxin A, which we'll discuss in just a moment. Clostridium difficile that causes disease is found in the feces, but it's normal in about 3% of healthy adults. They can have this organism without having disease. The spores can survive for very long periods, as you know, in the environment, particularly on surfaces in a hospital room or in a home. And it can be spread by hands that touch those contaminated surfaces. Now, we've seen this organism in gram stains in the laboratory. If you look at the picture on the left there, you'll find that it is this classic gram-positive rod, as you would expect any Clostridium to be. But in the top right, you begin to see the spores of this organism as being unstained spaces within the gram-positive cells. Again, classic for many Clostridium species, particularly Clostridium difficile. The colonies, as they appear on anaerobic blood agar, are in the bottom right slide. And as we know, these cultures, when you grow them in the laboratory, have a terrible odor to them. They smell very much like a barnyard. So pretty classic for Clostridium difficile in the laboratory. Now let's look at toxin A and toxin B and their activities here just for a moment. And I want you to note that toxin B may be more important than toxin A. Now toxin B causes the opening of the tight junctions of intestinal epithelial cells, and that increases vascular permeability to induce hemorrhaging, which of course is an indication of severe damage within the intestine. Toxin A, on the other hand, leads to diarrhea by damaging the villus tips that disrupt the brush border membrane, leading to cell erosion and fluid leakage, resulting in diarrhea. So let's examine the epidemiology of this disease for just a moment. Clostridium difficile infection occurs primarily in people who are taking antibiotics. They also occur in the elderly and the combination of elderly taking antibiotics. And this elder group and groups that are immunocompromised that are at greatest risk. In fact, about 80% of Clostridium difficile infections in the United States are hospital associated, while 20% of the infections are community acquired. And this is rising and becoming a little more concerning for us. Many commonly prescribed antibiotics can lead to Clostridium difficile infection, including ampicillin, amoxicillin, the cephalosporins, erythromycin, and the quinolones like ciprofloxacin and levofloxacin. Now, some of these diseases can be picked up simply from touching feces-contaminated surfaces. And again, these can be in the home. They can also be in the hospital environment. So where might these infections come from? C. diff infections really may not always be acquired from symptomatic patients. It may not be the patient that is in your hospital or that you're seeing may in fact not have gotten their infection from another infected patient. Researchers at the University of Oxford found that over half of their patients got their sources of organisms from water, from pets, from farm animals, or food. And they proved this by performing gene sequencing on almost 1,000 isolates obtained from symptomatic patients. So asymptomatic carriers may be a major source of infection. In Pittsburgh, the study found that 29% of infected patients that they studied contracted their disease from asymptomatic carriers. Now, these carriers are people that had Clostridium difficile organisms but were not themselves showing symptoms of the disease. So asymptomatic carriers can be important in the spread of this illness. Clostridium difficile is responsible for 20 to 30% of the cases of antibiotic-associated diarrhea, and for virtually all cases of antibiotic-associated pseudomembranous colitis. It is, as we know, the leading cause of nosocomial infectious diarrhea in adults and can be responsible for large outbreaks. In fact, we see over 500,000 cases in the United States annually, and that's just the ones that are reported. Up to 20% of these patients will get reinfected. They will get sick again. And this perhaps because the initial infection was not fully cleared, or it could be as a result reinfection with a different strain of Clostridium difficile. After one recurrence, further recurrence may appear up to 65% of the time, particularly in older patients, patients older than 65 years old, those that are taking other antibiotics while being treated for Clostridium difficile, and those that exhibit comorbid conditions such as kidney disease, inflammatory bowel disease, and liver disease. So regarding relapse as opposed to a new infection being caused by a different strain, a study have been performed to show that of patients with second episodes that occur before 8 weeks or within 2 months of the first episode, 88% of those had the exact same strain. In that study, patients with second episodes that exhibited after 8 weeks of the initial infection, only 65% had the same strain. And there were similar results from other studies. With that in mind, however, diarrhea after an initial episode of Clostridium difficile infection may not be due to Clostridium difficile. It has to be re-examined to determine if, in fact, it is a Clostridium difficile infection or some other cause of diarrheal infection. The organism is shed in the feces, and as so, it can be transmitted person to person. Nosocomial Clostridium difficile infection results in an increased length of stay ranging from 8 to 21 days. And if you couple that with the fact that the cost of in-house hospital stays range from $1,600 to many times over $3,000 per day, depending on where the patient is located, this becomes a very expensive proposition for the hospital and for the patient too. Patients can be contaminated from any environmental surface. from shared instrumentation, from other hospital personnel's hands, and infected roommates. But all of this is essentially a result of fecal contamination, and usually from people that have not washed their hands appropriately. It can be spread through the hospital environment where the spores can persist for many months and can be very difficult to get rid of. Now, some people have been very effective in ridding their facility, or at least easing the infectious risk within their facility by using several methods. One is accurate and rapid diagnosis. That's clearly our role in the laboratory. Appropriate treatment and quick, fast treatment. Implementation of enteric precautions for symptomatic patients. Reinforcement of hand washing as often as necessary. Daily environmental disinfection, and having a restrictive antibiotic policy. Now, hospitals may use one or all of these, or any combination of them, and they have all been shown effective to some degree in reducing the incidence of Clostridium difficile infections. Now, with these infections, we have a summary case definition, and that is, this case definition should include the presence of symptoms, usually always diarrhea, and either a stool test result positive for Clostridium difficile toxins or a toxigenic strain of Clostridium difficile that has been cultured. In addition, it could also include a colonoscopic finding that demonstrates pseudomembranous colitis. So there's our summary definition of the infection. So is it colonization or infection? Now, colonization, as you know, is essentially where the patient has the organism in the intestine but exhibits no clinical symptoms. These are usually non-toxigenic strains and are really more common than true infection. And infection occurs, of course, where the patient is exhibiting clinical symptoms and the patient tests positive for the organism and its toxin or the toxin alone. Now, the symptoms are watery diarrhea, and that's defined as being 3 or more loose bowel movements per day for 2 or more days. Fever, loss of appetite, nausea, abdominal pain and tenderness, and it is also a cause of pseudomembranous colitis. Now, this disease can be extremely serious for patients, and it must be diagnosed and treated immediately or risk serious complications such as toxic megacolon, perforations of the colon, sepsis, and even rarely death. Now, we are familiar with the sequence of events that usually occurs here. First, something happens to alter the normal gut flora. It's changed. Usually that's due to the administration of antibiotics, perhaps for a completely unrelated illness. The antibiotics kill the organisms in the gut, and the balance is destroyed. And it leaves a vacuum of commensal flora, which will be filled, in this case, by Clostridium difficile. And as a result, we have a nosocomial infection or a hospital-associated infection with Clostridium difficile. The organism grows in the intestine. It produces its toxins, A and B. The tissue damage, usually by toxin A, and that's exacerbated by toxin B. And then, of course, we see the diarrhea followed by colitis. We do have guidelines for treatment, diagnosis, and preventing infections. And we can look at some of those. Number one, only stools from patients with diarrhea should be tested. It is not recommended that we test for Clostridium difficile in formed stools. Only diarrheal stools. Others should be rejected unless ileus is associated with this patient. Nucleic acid amplification tests, such as PCR, for the Clostridium difficile toxin genes are superior to toxins A and B testing alone as a standard diagnostic test for this infection. Glutamate dehydrogenase screening test for Clostridium difficile can also be used in a 2 to 3 step screening algorithm with subsequent toxin testing by enzyme immunoassay, but the sensitivity of this process may be a little lower than the PCR alone, but it's still very good when you combine the GDH plus the nucleic acid amplification test. Repeat testing on the same patient should not be done, should be discouraged, and certainly testing for cure should not be done with this organism. And that comes into play when perhaps patients from nursing homes come into the hospital and the nursing home is saying they want to see a subsequent negative test before they accept this patient back into the nursing home. No, we can't do that. That is essentially doing a test of cure, and no one recommends a test of cure using PCR or any of the enzyme immunoassay tests. We do see a new strain that's becoming more prevalent in the United States, and it's increasing in number and in the severity of the cases. The group that is most likely to become infected with this strain appears to be the elderly, especially those that are taking antibiotics. And in fact, community-acquired individuals also have seen this new strain, along with peripartum women. This new strain is called the NAP1 strain, or the North American Pulsefeel type 1 is how it got that name. And it's also called the PCR ribotype 027. First began to appear in Pittsburgh and Atlanta and Montreal, and it's been shown that this organism, this NAP1 strain, produces quite a bit more toxin than the garden variety, if you will, strain of Clostridium difficile produces. For instance, 16 times the amount of toxin A and 23 times the amount of toxin B is produced. And while this organism phenotypically is more resistant to fluoroquinolones, the fluoroquinolone is not a recommended therapy for this organism, but it is an observation of the difference in this particular strain. Now, what can we do in the laboratory to very quickly identify this organism and get the information back to the physician? Well, first of all, we can culture if necessary. The bacteria will grow on special media under anaerobic conditions, but it takes anywhere from 48 to 96 hours to get results. And then, even with the colonies identified on the agar, we still have not done a toxin test. So we don't know whether this is a toxigenic strain or not. So culture is one way. Genetic test, nucleic acid amplification test, is another. This test for the bacterial gene that produces the toxin. It does not test for the toxin itself. So NAATs are very sensitive and they're very specific, but they are a lot more expensive. And we can get these results within 1 to 3 hours, depending on the type of PCR that you're using. Now, rapid antigen detection is very commonly used throughout the United States because it is fast and is much less expensive. Its results can usually be attained within an hour of the time testing is instituted. Very commonly used, and it's often combined with tests for toxin or combined with genetic tests. And then finally, toxin testing itself, either by tissue culture or by enzyme immunoassay for toxin A and toxin B. So there are the four primary means of laboratory test: culture, genetic testing, antigen detection testing, and toxin testing. So are toxin detection kits sufficiently accurate to be used as a single test to detect C. difficile toxins? So in other words, do we just want to use toxin A and B testing? The currently available kits for detection of Clostridium difficile toxin have variable performance. In fact, many of them may miss 1 in 5 to 1 in 10 cases of Clostridium difficile infections and will falsely identify 1 to 2 out of 10 cases as positive when they are not. So the poor positive predictive values of the toxin detection kits, especially in the context of widespread testing that we see in the United States, and the possibility of missing true positives mean that there are limitations to using these toxin tests as the only test for the laboratory diagnosis of Clostridium difficile infection. In fact, they're not recommended to be used alone. Now here's a study where of 600 strains that were subjected to a number of commercially available toxin tests. And you see this list of tests on the left-hand side of the screen. But if you'll notice under sensitivity, the confidence intervals are very broad in this and range from the 60s into the 80s. And so the sensitivity range in this study showed that toxin tests alone were not really sensitive enough to be acceptable for the only test that a laboratory would use. Now there is another rapid test that's available called the glutamate dehydrogenase test, or the GDH. So all Clostridium difficile strains appear to produce the cell wall associated enzyme glutamate dehydrogenase. And it's an antigen. The GDH antigen appears to be highly conserved among Clostridium difficile ribotypes. And they have been shown to be highly sensitive, but poor specificity for the detection of toxigenic Clostridium difficile. So the GDH component of these tests has variable results also. The GDH assays have been widely used as screening tests for Clostridium difficile and have been highly recommended in European guidelines as well as US guidelines. So essentially what the GDH is testing for is the presence of the organism, not the presence of the toxin. Here's a study that combined the enzyme immunoassays for glutamate dehydrogenase as well as nucleic acids, the nucleic acid testing in PCRs. If you'll notice in the red marked area, you'll notice that the sensitivity for the GDH enzyme immunoassay alone and the sensitivity for the PCR alone were very, very similar. The toxin, however, the toxin test had a very low sensitivity, whereas the specificity for the toxin test were relatively high. And the toxin tests for the GDH and the NAATs were also very similar. However, with the PCR, there is a potential Achilles heel here for this type of test because they do not detect the presence of actual toxin, which is considered as the sine qua non test for Clostridium difficile infection. It tests for the toxin genes. It doesn't say whether or not that gene is turned on or turned off. Now, elderly inpatients typically have Clostridium difficile toxigenic culture positive rates of 10 to 20%. In one study of 271 patients, 14% of those were colonized with C. difficile on admission, including 18 who were asymptomatic. A further 47 patients in this study, or 17% of them, became colonized during their hospital stay, and 19 of those remained asymptomatic throughout their hospital stay. So colonization by Clostridium difficile can be protective against the development of Clostridium difficile infection if it's accompanied by an antitoxin antibody response, so they can be helpful. Now, with nucleic acid amplification test, we know that the real-time PCR is highly sensitive. It detects the genes and not the active toxins, we know that, and it cannot distinguish infection from carriage. However, as the rate of infection in an institution or a community increases, the positive predictive value of the PCRs also increase. In this study, it showed that a rate of an infection rate of as low as 10% or less, the positive predictive value of the PCR was only 71%. But as that rate of infection increased in the population to 20% or more, that positive predictive value becomes 93%. And still did have some false positive results. So PCR is not without its problems, but it is very sensitive and it is very specific, and it's used quite frequently throughout the country now as the source of results for Clostridium difficile infection. Now, we know that about 25% of the primary Clostridium difficile infection cases have recurrence of symptoms following treatment. Long-term Clostridium difficile gut colonization is also frequent. In an endemic infectious setting, 56% of the patients were actually asymptomatic Clostridium difficile carriers 1 to 4 weeks after treatment stopped. This is one reason why we don't do test of cure, because the organism remains present, or certainly the genes remain present for quite some time. So the significance of a positive Clostridium difficile PCR test after an episode of infection and therapy is really unclear. So these examples emphasize the importance of appropriate specimen selection and clear clinical details. When the infection started, when treatment was begun, and is this a test of cure or not? Let's ask the question then, if the first PCR is negative, should I order another PCR? Well, basically the answer is no. You should not order another PCR. This study of 406 tests from almost 300 patients with the first negative PCR showed that 97.5% of those remained negative. There were only 10 patients that tested positive after that initial negative PCR, and only 3 of those were positive in less than a week. The others were positive greater than a week after that first initial test. So repeating a negative test by PCR is just not recommended. If you look at what others are doing across the United States, I took a sample of colleagues' facilities in 15 different cities. Many of them used PCR alone, where you see the NAAT, the NAT there. A few were using algorithms, and one in this group were using enzyme immunoassay. And look at the difference in the percent positive that they were seeing in their patient populations. The enzyme immunoassay population testing method showed only 8% positive, whereas both the PCR and the algorithm, which used a combination of enzyme immunoassay, GDH, and PCR, showed almost twice the positive percentages that the enzyme immunoassay alone was showing. And the algorithm and the PCR were very closely aligned in the percent positive. So they were both very effective. If you look at the bottom down here with the yellow, the PCR average alone was 16.5% positive in this group, whereas those that were using algorithm, the percent positive was 15.3, which was very close together. So the recommendations that came out in 2013 showed some acceptable strategies that we can use in our facilities in the laboratory for diagnosing this disease. The enzyme immunoassay for glutamate dehydrogenase and or the toxin assay with a molecular assay for discrepant results. That's one way to do it. In other words, if you have GDH and toxin on the same test, and they are both positive, they're likely to be positive. If they are both negative, then it's probably a true negative. But if they disagree, then that should certainly be followed up with a PCR. Now, many people just use the GDH and the PCR alone as a combination algorithm, and it works very nicely for them. In addition, many facilities use PCR alone, and that's a wonderful way to do this analysis, do the test. But it is unacceptable to use toxin A and B testing as the only standalone test for Clostridium difficile infection. So how is this disease treated? In about 20% of the patient, infections are going to resolve on their own within 2 to 3 days of discontinuing the antibiotic that patient is taking. That's about 20% of the patients. Treatment, however, usually lasts about 10 days in uncomplicated cases, and the recommended treatment involves metronidazole or vancomycin, both oral, or fidaxomicin. Now, there are other treatments, as you know, that have become prominent and very effective. And one is fecal transplants. Now, as unpleasant as this sounds, they actually work very nicely. The European Society for Clinical Microbiology released an algorithm for the treatment of various types of infections that included the use of probiotics and fecal transplants for cases with multiple recurrences. In other words, treatment was unsuccessful in the first or second episodes. Researchers from the University of Calgary have used pills made up of feces from family members of the afflicted patient, and they were very effective. And in fact, in one study of 27 patients that were treated and tested in this method of fecal transplants, all of them were successfully treated and experienced no recurrence of disease, whereas antimicrobial therapy was not effective. Only the bacteria was extracted from the feces, and this slurry was encased in a triple layer of gelatin capsules to help survive the acid conditions of the stomach before it reached the small intestine. Now, in the United States, the Food and Drug Administration is considering the fecal transplants as an investigational new drug, an IND, and have drafted some guidance for facilities to use and have placed specific limits on the use of this as an investigative new drug. Now, more guidance may be coming forward, more regulatory control may be coming forward, but right now physicians can proceed without filling out an IND if they have done 2 or 3 things. One, they have received the appropriate informed consent from the patient indicating that fecal transplants are an investigative therapy, that the donor source is known, and that donor screening by a licensed laboratory has been completed and was successful. Now, here are the results of 5 studies that have shown just how effective this is. So the cure rates range from 81 to 95%, and it's been very effective. And there's a website that you can observe there if you wish. Now, the sources for the information I've been talking about today have come from the Center for Disease Control and Prevention on their website, and also IDSA, the Infectious Disease Society of America, and their guideline on gastrointestinal diseases. So you're certainly welcome and should keep up with these sources for any updates that occur in the future. So looking at the Infectious Disease Society of America strategies for testing, they indicate that testing for Clostridium difficile or its toxins should be performed only on diarrheal stool, as we talked about. Testing of stools from asymptomatic patients is not clinically useful, including the use as a test of cure. Stool culture is the most sensitive test and is essential for broad epidemiological studies. Now, although stool culture is not clinically practical because of its slow turnaround time And most hospitals they are not going to do culture, anaerobic culture for Clostridium difficile. The sensitivity and specificity of stool culture, followed by the identification of a toxigenic isolate, is very important and should be performed by only an experienced laboratory. Enzyme immunoassay testing, these rapid tests for toxin A and B, is less sensitive than the cell cytotoxin assay. And most hospitals do not have the capacity to do a cell cytotoxin assay. So thus, the toxin A and B test is a suboptimal approach for diagnosis. But toxin testing is important clinically. It's just not very sensitive. So one potential strategy to overcome this problem is to develop an algorithm, and one is a two-step algorithm that uses enzyme immunoassay detection of glutamate dehydrogenase, or the GDH, as an initial screening, and then use either the cell cytotoxic assay or toxigenic culture as the confirmatory test for the positive stool specimens. Now, this, of course, depends on the type of GDH test that you use, and you have to be careful as you decide which is the best test to use in your hospital. Okay? Now, PCR testing appears to be rapid, sensitive, and specific, and many places have gone now to completely using PCR as the only test. And this test can ultimately address these testing concerns. And we need more data on its utility before it's recommended as a complete routine testing for all hospitals. Many facilities cannot afford PCR testing for Clostridium difficile, and they choose to use a combination or some of the others. Repeat testing during the same episode of diarrhea is not recommended and really should be discouraged. So what we've talked about today is that Clostridium difficile testing has improved dramatically just in the past 3 years. And we're seeing great improvements in sensitivity and specificity, particularly with the addition of PCR as a test or by the use of an algorithm using GDH, toxin, and the PCR. Limiting the testing to only at-risk patients with clinically significant diarrhea is absolutely essential. Eliminating repeat testing unless it is clinically necessary and not performing a test of cure. And it's also very helpful for those hospitals and those facilities that tend to have an increasing patient load of Clostridium difficile infection patients to create a CDI or Clostridium difficile team to look at the diagnostics, to look at the epidemiology, and to look at the options available to you as a team of healthcare professionals to work with this organism. Thank you for your attention, and I appreciate you joining us for this presentation.